So I'm going to talk about the pengicula, which is a fairly common condition affecting the conjunctiva. Pengicula is an extremely common degenerative condition of the conjunctiva. It is characterized by a formation of a yellowish white patch on the bulbar conjunctiva near the limbus. And this condition is termed pengicula because of its resemblance to the fate, which means pinguis in Latin. Etiology has been considered as an age-related change. This is occurring more commonly in persons exposed to the strong sunlight, dust, and the wind. It was considered as a precursor of the pterygium by many workers. Currently, it is suggested that the pengicula does not progress to pterygium, and the two are actually the distinct disorders. Pathology of the pengicula. It is an elastotic degeneration of the collagen fibers of the substantia propria of the conjunctiva. There is a deposition of the amorphous hyaline material in the substance of the conjunctiva. The clinical features of the pengicula. It is bilateral usually. It is usually a stationary condition. It presents as a yellowish white triangular patch near the limbus. Apex of this triangle is away from the cornea. It affects the nasal side first and then the temporal side. When the conjunctiva is congested, it presents as an avascular prominence. So whenever there is a conjunctivitis, this stands out prominently as the avascular prominence. As far as treatment of pengicula, in routine there is no treatment required. However, when cosmetically unacceptable, it may be excised, and when inflamed, it should be treated with the topical steroids. Its complications include inflammation, intraepithelial abscess formation, rarely calcification, and sometimes it can convert into the pterygium. Another commoner condition, it's a fairly common situation and a fairly common disorder, and that is called pterygium. I'll take you through this. Pterygium means wing. In Latin, it is called pterygion. It is a wing-shaped fold of the conjunctiva encroaching upon cornea from either side within the interpalpebral fissure. Etiology: the disease, pterygium, is more common in people living in the hot climate and in those who work outdoors. Therefore, the most accepted view is that it is a response to the prolonged effect of the environmental factors, such as exposure to the sunlight, that is the ultraviolet rays, dry heat, high wind, and abundance of the dust. All these factors, they contribute, and they are more predominantly seen in those who work outdoors. Pathology of the pterygium. It is a degenerative and hyperplastic condition of the conjunctiva. The subconjunctival tissue undergoes elastotic degeneration. It proliferates as vascularized granulation tissue under the epithelium, which ultimately encroaches the cornea. The corneal epithelium, the Bowman's membrane, and the superficial stroma, they are all destroyed. So we can say it is basically a degenerative and a hyperplastic condition of the conjunctiva. Clinically, the demographic features include the age, which is usually seen in the old age. Gender is more common in the males. They are more exposed to the outdoor work than the females. Laterality, it may be unilateral or bilateral. It is usually present on the nasal side, but may also occur on the temporal side. Symptoms. A cosmetic intolerance may be the only issue in otherwise asymptomatic condition in the early stages. So a cosmetic blemish may be the only presenting feature. Sometimes there can be foreign body sensations and irritation may be present. Defective vision occurs when it encroaches upon the pupillary area or due to the corneal astigmatism. Diplopia can occur occasionally due to the limitation of the ocular movements. Signs of the pterygium is seen as a triangular fold of the conjunctiva encroaching on the cornea in the area of the palpebral aperture, or we call it palpebral fissure. It is usually seen on the nasal side in the typical presentations. However, it may also occur on the temporal side. Very rarely, both the nasal and the temporal sides are involved. We call it primary double pterygium. The Stocker's line is actually a deposition of the iron, which may be seen in the corneal epithelium anterior to the advancing age of the head of the pterygium. So these are the different parts of the pterygium: head, neck, body, and the cape. The head is the apical part present onto the cornea. The neck is constricted part which is present at the limbal area. Body is the scleral part which is extending between the limbus and the canthus. But cape is a semilunar whitish infiltrate present just in front of the head. Now these are the different types based on the extent of the pterygium. Type 1, it extends less than 2 mm onto the cornea. Type 2, which involves up to 4 mm of the cornea. Type 3, which encroaches beyond 4 mm of the cornea and involves the visual axis. So based on the extent of the pterygium, it has been divided as type 1, 2, or 3, with the increasing severity in that order. It has also been classified depending on the progression as progressive pterygium. The progressive pterygium is thick, fleshy, and vascular with a few whitish infiltrates in the cornea. In front of the head of the pterygium, which is known as Fuchs spots or islets on the wall, also called the cape of the pterygium. So what we understand by the progressive pterygium, there is a thick, fleshy, and a vascular growth with whitish infiltrates in the cornea. The regressive pterygium actually does not regress, but is stationary. It is actually a thin, atrophic, attenuated, and very little vascularity. There is no cape, but deposition of the iron or the Stocker's line may be seen sometimes, just under the head of the pterygium. Ultimately, it becomes membranous, but it never disappears. Right? Now, what are the complications of the pterygium? Cystic degeneration and infections are frequent. Neoplastic change to epithelioma, fibrosarcoma, or malignant melanoma can occur. It is actually a transformation into the malignancy. The pterygium has to be differentiated from pseudopterygium. The difference between pterygium and the pseudopterygium can be considered under these heads. First is the etiology. Pterygium is a degenerative process, whereas the pseudopterygium occurs following inflammation. The pterygium usually occurs in the elderly persons, whereas pseudopterygium can occur at any age. Site: the pterygium always situated in the palpebral aperture, where the pseudopterygium can occur at any site. The pterygium can be either progressing, regressing, or stationary, but pseudopterygium is always stationary. And a probe test can be performed. The probe cannot be passed underneath a pterygium, whereas a probe can be passed under the neck of the pseudopterygium. The treatment of pterygium consists of clear substitutes, which may be used in patients with small regressive pterygium for the dry eye symptoms. Topical steroids may be required for the associated inflammation. Protection from the ultraviolet rays with sunglasses decreases the growth stimulus. So these are some of the measures that can be considered. However, surgical excision is indicated in certain situations, such as cosmetic disfigurement, visual impairment due to the significant regular or irregular astigmatism, or diplopia due to the interference with the ocular movements. So these are the situations that demand surgical excision of the retina. There can be a condition of the recurrence of the pterygium wherein the surgical excision with free conjunctival autograft, which is taken from the same eye or the other eye, is present in the preferred technique. Surgical excision with amniotic membrane graft and mitomycin C, that is 0.02%, may be required in recurrent pterygia or when dealing with a very large pterygium. Surgical excision with lamellar keratectomy and lamellar keratoplasty may be required in deeply infiltrating recurrent recalcitrant pterygia. Old methods to prevent recurrence, which is not used now, is the transplantation of the pterygium in the lower fornix. We call it Mac-Reynolds operation. And the postoperative use of the beta radiation, it is used with the help of strontium 90. These are the older methods which are not used nowadays. Another commoner condition of the conjunctiva, which I am going to talk about now, and that is called ophthalmia neonatorum. The ophthalmia neonatorum is a bilateral inflammation of the conjunctiva occurring in infancy below 30 days old. We can call it neonates. So ophthalmia neonatorum typically involves the neonates. Any discharge or even watering from the eye in the first week of life should arouse the suspicion of ophthalmia neonatorum. Etiology of ophthalmia neonatorum. The source and the mode of infection. Infection can occur in three ways: before birth, during birth, or after birth. Before birth, the infection is very rare through the infected liquor amni in the mother's ruptured membranes. During birth, vaginally delivered infants, the most common mode of infection is from the infected birth canal, especially when the child is born with the face presentation or with the forceps. And after birth, the infection can occur during the first bath of the newborn or from the soiled claws or fingers with infected lochia. These are the causative agents. The chemical neonatal conjunctivitis is caused by the silver nitrate, which was used commonly in the olden days, or antibiotics used for the prophylaxis. Whereas the gonococcal infection was considered as a serious disease in the past, as it used to be responsible for almost half of the blindness in children. But the decline in the incidence of the gonorrhea, as well as effective methods of prophylaxis and treatment, have almost eliminated it in the developing countries. As far as the other bacterial infections responsible for the ophthalmia neonatorum, they include Staphylococcus aureus, Haemophilus species, Streptococcus pneumolyticus, Streptococcus pneumoniae. The neonatal inclusion conjunctivitis is caused by the serotype D to K of the Chlamydia trachomatis, and is at present the commonest cause of the ophthalmia neonatorum in the developed countries. Herpes simplex ophthalmia neonatorum is a rare condition. It is caused by the herpes simplex type 2 virus from the infected birth canal. The clinical features include incubation period. The causative agent is, and the incubation period is shown in this table. If it is chemical, it is 6 hours. For the gonococcal infection, 2 to 5 days. Other bacteria, 5 to 8 days. Neonatal inclusion, 5 to 14 days. And herpes simplex, 6 to 40 days. So the incubation period is quite variable. As far as symptoms and signs, pain and the tenderness in the eyeball. Conjunctival discharge is purulent in the gonococcal and mucoid or mucopurulent in other bacterial cases, and in neonatal including conjunctivitis. Lids, they are usually swollen in the infective cases. Eyelids in the periocular vesicles may occur in herpes simplex virus. Conjunctiva may show hyperemia and chemosis. There might be mild papillary response in neonatal inclusion conjunctivitis and herpes simplex, ophthalmia, and neonatal. Follicular response is typically absent in the infants because of the immaturity of the lymphatic systems up to the 6 to 8 weeks of life. So typically, we do not see any follicles in the case of ophthalmia in that term because of the immaturity of the lymphatic system. The corneal involvement, although rare, may occur in the form of superficial punctate keratitis, especially in herpes simplex, ophthalmia, and neonatal. In an untreated case, especially gonococcal ophthalmia and neonatal, there can occur a corneal ulceration, which may perforate rapidly, resulting in a corneal opacification or scapular formation. As far as prophylaxis, there are antenatal measures which must be adopted. It includes a thorough care of the mother and the treatment of genital infections when suspected, surveillance of the woman during the third trimester of pregnancy for the evidence of chlamydia, herpetic, or gonococcal infection. That is critical in prevention of neonatal conjunctivitis. The natal measures are of the utmost importance as mostly the infection occurs during childbirth. Deliveries should be conducted under the hygienic conditions, taking all the aseptic measures. The newborn baby's closed lids should be thoroughly cleaned and dried. The postnatal measures include povidone iodine 2.5% solution to be used. It is an effective agent against most of the common pathogens and is widely used. Use of either 1% tetracycline ointment or 0.5% erythromycin ointment in the eyes of the babies immediately after the birth are useful for preventing bacterial and chlamydial ophthalmia and neonatal. Single injection of ceftriaxone 50 grams per kg intramuscular or intravenous, not exceeding 125 milligrams, should be given to the infants born to mothers with untreated gonococcal infection. The treatment of chemical ophthalmic neonatal. Chemical ophthalmic neonatal is a self-limiting condition and does not require any treatment. Other bacterial ophthalmia neonatal should be treated for 2 weeks by a broad-spectrum antibiotic drops and ointments such as neomycin bacitracin or atobromycin preparation. Gonococcal ophthalmia neonatal requires a topical therapy in the form of number 1, saline lavage hourly till the discharge is eliminated. Bacitracin eye ointment 4 times a day. Because of the resistant strain, topical penicillin therapy is not reliable. However, in cases with improved penicillin susceptibility, penicillin drops 5,000 to 10,000 units per ml should be instilled every minute for half an hour, every 5 minutes for next half an hour, and then half hourly till the infection is controlled. That is the regime when we use penicillin. If the cornea is involved, atropine ointment should be applied. Systemic therapy includes for the neonates with gonococcal ophthalmia, they should be treated for 7 days with one of the following regimes. Ceftriaxone 75 to 100 milligrams per kg per day intramuscular, or cefotaxime 100 to 150 milligrams per kg per day intravenous or intramuscular 12 hourly, or ciprofloxacin 10 to 20 milligrams per kg per day, or norfloxacin 10 milligrams per kg per day. Or if the gonococcal isolate is proved to be susceptible to penicillin, then crystalline benzyl penicillin G 50,000 units to a full term normal weight babies and 20,000 units to premature or low weight babies should be given intramuscularly twice a day for 3 days. Neonatal inclusion conjunctivitis responds well to the topical tetracycline 1% or erythromycin 0.5% eye ointment 4 times a day for 3 weeks. Alternatively, azithromycin suspension 20 milligrams per kg either as a single dose or once daily for 3 days should be administered. Herpes simplex conjunctivitis is usually a self-limiting disease. High dosage intravenous acyclovir is indicated in cases suspected of herpes, systemic herpes infection.